Perfect. So as we begin today's session, it is important to situate ourselves and reflect on the land that we reside on. I will begin with the land acknowledgement. We recognize that our work and the work of our members takes place on traditional Indigenous territories across Ontario. We also wish to acknowledge that the RNAO head office is located on the traditional and unceded territory of the Huron-Wendat, Haudenosaunee, and the territories of the Mississaugas of the Credit. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, which is an agreement with the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also acknowledge that Toronto is covered by Treaty 13 under the Toronto Purchase Agreement with the Mississaugas of the Credit. Today, this land is the home to many First Nations, Inuit, and Métis people from across Turtle Island, and we are grateful to have the opportunity to work on this territory. By personally making a land acknowledgement, you are taking part in an act of reconciliation, honoring the land and Indigenous heritage which dates back to more than 10,000 years. We encourage you to learn about the land you reside on and the treaties that are attached to it. Land acknowledgements are an act of reconciliation, and we must all do our part. I will now pass it over to Courtney to begin with introductions.
Hi, everyone. Thanks so much for being here this morning. So as Glynis mentioned, my name is Courtney Braun. I'm a guideline development methodologist here at the RNAO, and I'm delighted to present our presenters for today. So we have Dr. Celine Gélinas, who's a co-chair on the guideline and will be helping with the presentation this morning. I'd also like to recognize Dr. Lindsay Jibb, who was another co-chair on this guideline who was unable to make it this morning. And then we have our other presenters, Glynis Gittins, who you heard from, who's our project coordinator, Catherine Wallace, who's an implementation science manager, and Dr. Christina Medeiros, who's also an implementation science manager. So the objectives for this morning is to discuss the prevention, assessment, and management of pain and the value of using this BPG to improve the quality of care in your practice. So we will be providing an overview of the BPG, including the purpose and scope, the guideline development process, as well as a summary of the good practice statements and recommendations. And then following a short break, the RNAO team will discuss next steps for kickstarting implementation and evaluation of this BPG in practice settings. Like Glynis mentioned, there will also be a time for questions and answers at the end of the webinar. So before we begin, I'd like to give a bit of a background on the RNAO. So the Registered Nurses Association of Ontario is the professional organization representing registered nurses, nurse practitioners, and nursing students in Ontario. We are the strong, credible voice that leads the nursing profession to influence and promote public health policy and clinical excellence. A signature program of RNAO is the International Affairs and Best Practice Guidelines Program, the IBPG Center, which houses the Best Practice Guidelines Program. RNAO's BPGs are actively implemented across Canada, as well as internationally through partnership with Best Practice Spotlight organizations, BPSOs, and the Healthy Policy Program is another core pillar of RNAO. We'd also like to recognize that our funding is provided by the Government of Ontario, and they funded the BPG. And we also want to recognize that all the work produced by RNAO is editorially independent from its primary funding source. So the RNAO Best Practice Guideline Program was launched in 1999. The purpose is to develop, disseminate, and actively support the uptake and sustainability of evidence-based clinical, healthy work environment and system BPGs, as well as to evaluate their impact on patient, organizational, and health system outcomes. We've currently developed 54 best practice guidelines and a variety of implementation toolkits to support the implementation process. Here on this slide, you'll see RNAO's integrated BPG model that includes 3 pillars of guideline development, guideline dissemination, implementation, and sustainability, as well as guideline monitoring and evaluation. These pillars inform one another and work in sync to improve outcomes for persons receiving care and providers, organizations, and systems. During this webinar, we will focus on all 3 pillars as they relate to developing, implementing, and evaluating the clinical practice of the pain BPG. It's also important to mention that best practice spotlight organizations, or BPSOs, who enter into formal partnerships to implement the BPGs are located across Ontario, Canada, and internationally. Over the past 2 decades, the BPSO program has spread to include over 1,000 BPSOs globally. So from that previous slide, you'll remember that RNAO's integrated BPG model contains 3 pillars, and the pillar at the top of the slide was BPG development. This slide outlines the guideline development process, which we'll go into more detail later on in this presentation. So specific to pain with this BPG, I'd like to provide a little bit of a background. So we'll first start with the International Association on the Study of Pain's definition of pain, which is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So there are many different types of pain, and all types of pain are included in the scope of this guideline. So we have acute pain, which is sudden pain serving as a warning to the body, lasting less than 6 months. We have chronic pain, a multifactorial condition lasting and persisting longer than 3 months, and it's often the predominant issue. Nociceptive pain, which is physical pain caused by the activation of nociceptors in the body. Examples are burns or scrapes. We have neuropathic pain, which is nerve pain caused by damage to the nervous system, often causes numbness or tingling. We have nociplastic pain caused by activation of nociceptors with no clear evidence of tissue damage. We have mixed pain, which is a mix of different types of pain, as well as total pain, which is a multidimensional nature of pain that includes the physical, psychological, behavioral, and social elements of the pain experience. So pain is one of the top 5 reasons in Canada why people visit their primary care providers, and it's been identified as a public health priority. The number of people experiencing pain is expected to grow by 17% by 2030, so it's important to address this issue. So as I briefly mentioned in the previous slide, pain is multidimensional, with biological, psychological, and social factors contributing to the experience of pain. Biological factors encompass the physical aspects of pain. Psychological includes the emotions, attitudes, and values of the individual experiencing pain. And the social factors include cultural, economic, and educational influences. An individual's experience of pain is the intersection of all of these factors, and one cannot be considered in isolation. So this Venn diagram is from the European Federation of Pain. So like I said, an individual's experience of pain is the intersection of these factors. So to go into the purpose and scope of this guideline, the purpose is to provide nurses and members of the interprofessional team with evidence-based guidelines or guidance for the prevention, assessment, and management of all types of pain across the lifespan. This BPG recognizes that people at risk of or experiencing any type of pain across the lifespan and their families are experts in their health and decision-making. Collaboration among the interprofessional team, the person receiving care, and their families, if applicable, is therefore essential to achieving improved outcomes. So this BPG is to be used by nurses as well as members of the interprofessional team across the healthcare continuum in all domains of practice, caring for persons at risk of or experiencing pain. It is also to be used by employers, by health service organizations, and academic institutions. So this includes all domains of nursing practice, all healthcare settings and sectors, and all populations across the lifespan, including their caregiver and family. Unfortunately, what was outside of this scope was specific pharmacological management of pain, as well as pain assessment and management related to specific medical conditions. So this slide shows the development process of our BPGs. So we start from the pre-development work, which started back in 2022. We've come a long way since then. We completed topic selection and proceeded to form a panel of experts who were involved in determining the purpose, scope, and research questions for the guideline. The RNAO team then completed the systematic reviews and made the summary documents to share with the expert panel, who developed recommendations and good practice statements to be included in the best practice guideline. Then the RNAO team drafted the best practice guideline, which was reviewed by the expert panel, as well as external reviewers, Finally, the BPG was published, and we're now working on various dissemination activities, including this webinar. So this guideline could not have been created without the expert panel, who contributed their knowledge and expertise to the development of this resource. The expert panel was interprofessional in composition and included individuals with lived experience. Panel members have experience in clinical practice, education, research, and policy across a range of health and social service organizations, academic institutions, practice areas, and sectors. These experts share their insights on supporting and caring for persons and their support network when dealing with pain. On this slide, you'll see the names of the expert panel members, many of who are on the call today. The panel also played a key role in determining the BPG purpose, scope, and recommendation questions, and they provided feedback at various stages throughout the guideline development process on the draft BPG, indicators, implementation tips, and supporting resources. And then finally, as part of the guideline development process, the draft guideline was reviewed by end users. In this case, the guideline was reviewed by 89 external reviewers from within Canada and internationally, which further enhanced the rigor of this guideline. Their names can be found within the guideline. And then before we move forward, I would also like to acknowledge the entire RNAO team that was involved in bringing this guideline to life, but specifically Lauren Bailey, Deborah Flores, and our guideline development methodologists, Christine Buchanan, who is our acting senior manager, Glynis Gittens, our project coordinator, and our associate director, Nafsin. There were also many other RNAO team members that contributed to the development of this best practice guideline, including members of the implementation science team, monitoring and evaluation team, and executive stewardship. So I will now speak further about the guideline methodology. So it is important to note that when we develop our guidelines, we use grading of recommendations, assessment, development, and evaluation, or the acronym GRADE, approaches to support our rigorous guideline development process. GRADE is in line with international guideline standards, and it's used by other large health organizations such as the World Health Organization. So this guideline contains both good practice statements and recommendations. I wanted to walk through the difference between both statements, but what is important to remember is that they are both action-oriented statements based on evidence that make the guidelines something that can be implemented. They follow the same process for implementation. Good practice statements, though, are actions that must be done in practice. They may be seen as common sense actions, but they are not always happening in practice, hence the need to reinforce them in the guideline. We have high certainty that the benefits outweigh the harms, and the systematic review is not needed to determine this. In addition, researchers may no longer be conducting studies on the topic as the benefits are well known, or the alternative to the action may be unethical, so it would not make sense to study it further. Good practice statements do not receive a rating of strong or conditional, but they should nevertheless be interpreted as strong recommendations. An example of a good practice statement would be conducting an assessment before carrying out an intervention. Recommendations are also action-oriented statements, but they are developed based on evidence from a systematic review. They answer a research question about whether an action or intervention should or should not be done. They are determined to be strong or conditional by considering the benefits and harms of the action, how certain we are in the evidence, the values and preferences of people, and the impact on health equity. In the following slide, we will talk about strong versus conditional recommendations in further detail. Again, what I'd like to emphasize is that both statements reflect best practices and should follow the same process of implementation. So this slide gives you more detail to help you differentiate between a strong and a conditional recommendation. So as mentioned before, good quality evidence equates to strong recommendations. GRADE only considers randomized control trials or systematic reviews as high quality evidence, which may equate to a strong recommendation depending on their quality and rigor. Low or very low quality of evidence equates to a conditional recommendation. In general, GRADE discourages expert panel members from making strong recommendations based on low or very low quality evidence. But in a strong recommendation, most people will benefit from the recommended practice. And I will remind you that good practice statements should be interpreted as strong recommendations. Conditional recommendations are not bad or less important. There's just a need to consider more carefully than usual the individual patient's circumstances, preferences, and values. Therefore, not everyone will benefit from the recommended practice. What you see on this slide is a simplified PRISMA flow chart that indicates the rigorous process for the systematic reviews RNAO guideline team conducted for the recommendation questions. Our systematic reviews were helped by the health science librarian at UHN. Searches were conducted in 2022, and then they were updated in late 2024. To answer the research questions that informed our recommendations, we screened over 11,764 articles. Of these, 190 full texts were examined for relevance, and finally 25 articles were included. Each of the included studies were also quality appraised using the appropriate validated tools. More details on this can be found on our website, where you'll find the guideline under the Methodology Documents tab. As our guideline methodology has changed in the last few years with the use of the grade approach, our guidelines look a little bit different in terms of the way recommendations are presented, as well as with the inclusion of good practice statements. Our team has developed a mapping document. Part of the document is visible on this slide as an example, which helps to outline any changes or similarities in the new 4th edition guideline in comparison to the previous 3rd edition guideline. These documents can be used by the public to help implement the new recommendations. The implementation and evaluation teams will be going into more detail on how these documents can be used in practice later on in this presentation. Now, I'm happy to turn it over to Dr. Celine Molina, who will be presenting on the recommendations and good practice statements within the updated guideline.
Thank you. Can you hear me well? Yes?
Yep.
Okay, super.
Yep, we
Thank you.
can hear you, Celine.
Thank you. So I'm going to provide you some general guidance in terms of how to navigate the recommendation. So you will find in the guideline a recommendation statement box in which you have the recommendation statement as well as the strength of the recommendation and the certainty of the evidence. And below, you'll have a discussion of the evidence, which is described in different sections. So the first one relates to benefits and harms. So basically desirable and undesirable outcomes reported in the literature, followed by the values and preferences placed on outcomes from the perspectives of the target users. Health equity, highlighting the impact of the recommended practice on outcomes across populations and settings, as well as potential barriers to implementation of the practice in particular settings. The expert panel justification of recommendation, which is the rationale based on the literature. Implementation tips, so information in relation to what, who, where, when, and how in relation to the recommended practice, and supporting resources such as websites and tools. Can move to the next one. So in this guideline, there are 5 good practice statements and 3 recommendations that fall into 4 broad categories in the guidelines. So screening and assessment of pain, management of pain, interprofessional practice, and education. So we'll start with the screening and assessment. So the screening and assessment of pain are essential steps to adequate pain management. So it's a good practice statement. It didn't require a review of the evidence for this good practice statement, but it was deemed important to remind the community about this good practice, that all health providers to conduct initial and ongoing screening and assessment for pain with people in their care. So pain assessment includes a comprehensive evidence-based assessment using a person and family-centered care approach. So there are different tools available, and there is several tools presented in the guideline, although it's not an exhaustive list. But important to remember that pain assessment tools should be valid and appropriate to the population and context of care. So we can move to the next section. So regarding management of pain, so we have a good practice statement. So it is good practice for health providers to provide an integrative approach to pain prevention, assessment, and management. So in terms of an integrative approach, we refer to a combination of non-pharmacological and pharmacological strategies, including an individualized person and family-centered care approach. So as part of this section as well, there was a scoping review that was conducted on non-pharmacological strategies for pain management and is described also in the, is available in the guideline. So we can move to the next section on interprofessional practice. So we have a good practice statement. It is good practice for health service organizations and health systems to implement an interprofessional practice approach to pain prevention, assessment, and management. And we have a recommendation as well, which is conditional because the certainty of the evidence was very low. So the expert panel suggests that health service organizations provide access to a specialized interprofessional pain care team for the prevention, assessment, and management of pain for people experiencing acute or chronic pain. So as part of an interprofessional pain care team, we refer to nurses, physicians, pharmacists, physiotherapists, and many others. And although the certainty of the evidence was very low, no harms were reported in the literature, and this practice may offer a more robust and thorough pain management approach in clinical settings. So the last category is under the umbrella of education, and there are two main populations that are targeted. So students entering professions and also health professionals, health providers. So for students, to start with, a good practice statement. It is good practice for academic institutions to provide comprehensive education for students entering health professions on pain prevention, assessment, and management. And the recommendation, again, is conditional due to the certainty of the evidence that was low. So the expert panel suggests that academic institutions implement interactive education for all students entering health professions on pain prevention, assessment, and management. So in terms of interactive education, this is based on a dynamic approach that fosters active participation and exchange of ideas between learners and educators. And it may include various formats and modes of delivery, such as e-learning, web-based learning simulation, case studies, or group discussions. So although the certainty of the evidence was low, no harms were reported in the literature, and in terms of main outcomes, interactive education was found to improve student competency as well as attitudes and confidence towards pain management. So the next one and the last one, so education, but focusing on health professionals or health providers. So in good practice statement, it is good practice for health service organizations to provide interprofessional and discipline-specific education for all health providers on comprehensive pain prevention, assessment, and management. And recommendation, again conditional due to low certainty of the evidence, the expert panel suggests that health service organizations implement opportunities for interactive education for all health providers on pain prevention, assessment, and management. So this is the summary of the good practice statements and recommendations in the updated pain guideline. So I guess it will be time for the break. So maybe Glynis, you can specify the time we have.
Yep, perfect. Thanks, Celine. So right now it's 10:31, so we're going to give you about 10 minutes. So if you want to just come back at 10:41, that would be great. Thank you.
Thank you.
So we hope everyone's kind of making their way back. The time now is 10:41. So we can pass the presentation over to Catherine, who will be reviewing the implementation portion of the webinar today.
Thanks, Glynis. And wow, so exciting to see 167 people joining us today for today's presentation. That is amazing. So thanks everyone for your time. Now, Glynis, can I advance the slide?
Yeah, Courtney is going to be advancing the slides. Courtney, if you can just go to the next slide, please.
And while we're waiting for that, I'll introduce myself. Again, hi everyone. I am Catherine Wallace, Senior Manager, part of the Implementation Science team, and a pleasure to be with you today for our part 2 of this presentation, focusing on kickstarting your implementation of the PAIN BPG. If you are aware of these presentations historically, we typically used to focus on the guideline development, but in more recent presentations, when we have the release of a new BPG, we also focus on the 2 other pillars that make up our integrated BPG model, that include implementation as well as monitoring and evaluation. And this is exciting because, as we all know, the publication of a guideline, the reading of a guideline doesn't change practice, doesn't adopt all of those best practices that we've heard and the good practice statements. Instead, that takes an active process using evidence to inform how to adopt and integrate best practices. So that's the focus of this part 2 on implementation of the PAIN BPG. Next slide, please.
Catherine, I did give you control, so you should be able to advance the slides.
All right, let's give it a try. Thanks, Courtney. Perfect. Thanks. Okay, so my objectives, I want to talk more about this mapping document that Courtney introduced to you, and how it can help you in implementation of the 4th edition of the PAIN BPG. Ideally, this is for organizations that have used past editions of the PAIN BPG, and they're wanting to know what's new, what continues, and are there any recommendations or good practice statements that have that indicate a change or a stop in practice. So we'll talk a little bit about that and how you can use that resource to support your implementation of this new edition. And then I've got 5 actions to kickstart the BPG implementation for this new edition of PAIN for any end user. So again, here is this document that, or this slide that Courtney had shown us earlier. This is the mapping document. And what it shows you then is examples of, or a list of, some of the recommendations from the 3rd edition. And then in the 2025 edition, the edition we have now released on PAIN, where can you find relevant content in this new edition? So if you are a site that has implemented recommendation 1.2, that's the example we're going to look at today, that focused on performing a comprehensive PAIN assessment, well, then you're curious to know, then where can I find the relevant information in the 2025 edition? And so this document lays out for you where you can find that information so that you can ensure that your best practices that you are implementing from the 2013 edition now align with the 2025 edition. And that way, keeping best practices current, which we know is important in the field of implementation. So we're going to have a look at this again using the example of recommendation 1.2 from the 2013 edition, and then looking at from our 2025, what are the relevant good practice statements, the implementation tips, and we've got 2 appendices as well. Again, from the mapping document, you will find this. Perfect. So again, mapping documents for existing BPG users. You've been using the 3rd or 2nd edition of the PAIN BPG, and it helps you then to know which best practices from that older edition continue, what's new in best practices, and are there any best practices that should be discontinued? So let's look at some examples of continued best practices in the 4th edition of the PAIN BPG. And to determine this, what I did was review the 3rd edition for the specific recommendation, and then reviewed the mapping document and looked at what were the applicable good practice statement, the implementation tips, and the appendices to be able to develop this list of continued best practices. So in our 4th edition, we continue to see that pain assessments are comprehensive, systematic, they are uni or multi-dimensional, continue to be evidence-based as we would expect, be based on the use of valid and reliable tools, some of which are included in this BPG, are person-centered, are specific to the population across the lifespan, and are conducted and documented regularly. So again, if this is our current practice based on the 3rd edition, we can be assured that this continues to be best practices as per the mapping document and the details in the 4th edition. So what about what's new? And again, if we have implemented the 3rd edition, we're interested in knowing what else are we doing in terms of pain assessment that's informed by the 4th edition. So again, using the mapping document, we can find some new pain assessment components in the 4th edition. And these include, but are not limited to, strategies to facilitate pain assessment. And we've got some great tips from the expert panel. Our expert panel bring a strong knowledge of not only the research, but also of clinical practice, and share that to help support the development of our BPG. The new components also include a fulsome health equity and cultural safety considerations. And from Courtney's presentation, she was talking about how health equity is one of the components of the discussions of evidence. And so that includes an examination of cultural biases and implementing equity-focused care principles, including trauma-informed and harm reduction. So integrating those components into our pain assessment of our persons. And also an extended and updated list of valid assessment tools across the lifespan and by pain type, including diabetic neuropathy. Again, if that's of interest to you, you'll find that in the 4th edition of the BPG, and you would not have found that in the 3rd edition. Again, it's the advancement of new knowledge. And what should be discontinued in relation to pain assessment from the 4th edition? And for this specific recommendation from the 3rd edition, there were no discontinued practices regarding pain assessment. So again, regarding this mapping document, very helpful implementation tool for those sites who have implemented an earlier edition of the PAIN BPG. It will help you then to be able to find what are those new, continued, or possibly discontinued best practices. So please use that. And if you have any further questions, don't worry and just reach out to us. So let's talk about, in addition to this mapping document, 5 actions to kickstart implementation. And this would be relevant for a returning end user, so someone who's previously used the PAIN BPG or any other BPG, or someone who is new to implementation. And we've got 5 tips, and these we use as coaches from the implementation science team, as well as from the long-term care team, and we'll go through each of these briefly. So we're going to talk about reading the BPG, thinking about contextual factors and their impact. We'll talk about determining the readiness for change, assembling a change team, and completing a gap analysis. Okay, and a reminder that our Leading Change Toolkit is our online foundational implementation resource. It's evidence-based, and it's written for all of you as change agents, as change teams who want to make a lasting improvement in healthcare, and we do that in part by using BPGs to inform best practices. And in our Leading Change Toolkit, you'll find our 2 implementation frameworks. These are complementary, meaning we can use them together, combined, in order to effectively adopt and implement BPGs, including this 4th edition of the PAIN BPG. And the focus of our social movement action is that of people and getting people involved, engaged, participating to make practice changes, and a number of strategies in which we can do that. And then we also need to understand how we actually plan, make, and sustain change. And for that, in our Leading Change Toolkit, you'll find our the Knowledge to Action framework developed by Dr. Ian Graham and colleagues. And this helps us then to understand what are all of the action cycle phases that align with the process of making change. But in our Leading Change Toolkit, this focus on people, engagement, and the process in order to effectively adopt and integrate BPGs and other knowledge tools. In addition, in addition, is our best practice. Must be. Oh boy, sorry, let's go the other way. Perfect. Okay. There we go. I'm not going to touch anything. Okay, so in addition, another framework that we refer to, and this comes from our champions, our best practice champions competencies framework. So what we need are champions who are engaged in the implementation of a BPG, including the PAIN BPG. And our competencies framework details what roles do champions play in order to be effective in the adoption and integration of BPGs. And we discuss this and much, much more in our Champions Blended Learning series, and I've included the link there if you're interested in learning more. And we have a self-assessment tool that you can access as part of the resource library that makes up our Champions Blended Learning series. And one of those competencies of a champion is the ability to read and understand, make meaning of a BPG. We call those content experts. And so to be able to read a guideline that we know is a summary of best available evidence and be that meaning maker or sense maker, be able to communicate that to others, convey a positive attitude regarding best practices, and really that's acting as the starting point of being able to implement and adopt a best practice. And being able to read that guideline really helps us, and the discussion of evidence as well, being able to get started in thinking about how are we actually going to make a practice change as we begin that planning process. And a reminder that in November 2023 now, so about a year and a half ago, our colleagues, our guideline development methodologists, created a presentation. It was part of our Best Practice Champions information sharing webinar called How to Read, Use, and Interpret a BPG. So if you'd like to learn more about, for example, what is meant by a strong recommendation, or what's the difference between a good practice statement versus a recommendation statement, and much more, you can access this presentation online. Again, we've included the link there for you if you want to listen to that. And that can help you to understand how to read a BPG, really the starting point for being able to make change. In the guideline also, in addition to that discussion of evidence, are implementation tips. So for those of us engaged in the adoption and integration of best practices, this can be really helpful as it gives us some practical insight into how to actually make that practice change. And then I've also included here the Contact Us button that's available on the RNAO website. Should you have any questions, please reach out to us. We'd love to talk about the work that we do and help you in whatever way we can. For those of you who are joining from our Best Practice Spotlight organizations, hello to you. And a reminder that you have a friendly coach in the long-term care team, as well as the implementation science team. And they also are a wealth of knowledge and very happy to help you with any of the implementation of this guideline and any others. Okay, so we've read the guideline. We've got a good understanding of what the PAIN BPG is telling us in terms of best practices. Again, we've used that mapping document if we're wanting to know what's new in this BPG in comparison to the third edition. And then we have to consider some contextual factors. Remember that pain is something that exists across the lifespan, and pain is something that exists across sectors. So the guideline isn't written specifically for you, your patient person population, your sector. So it's important for us as end users then to think about the contextual factors. Um, and then to think about, who are the persons that we provide care to, the communities, persons, families, etc., who are our staff, and then that informs then the meaning of this BPG and the interpretation of those recommendations and good practice statements. And then we also think about, can we apply all of those recommendations and good practice statements in our setting? Do we need to consider any adaptations? Are there other care providers that might be involved? Are there some recommendations that may or may not be as applicable given our what our organizations provide in terms of care options? So a reminder that you can adapt a good practice statement or recommendation statement in your setting. The takeaway really is that the core components of the recommendations should still be applied. And that's somewhat of a subjective interpretation, but in some cases, organizations aren't able to adopt and integrate all of the options or all of the components of a recommendation, and adapting a guideline recommendation is something that's sometimes needed as a compromise, I guess, in terms of guideline implementation. So in our Best Practice Champions Blended Learning Series, again, we have a number of resources that are available for our champions. Again, this is a course that is available at no cost as our job aids. And these are documents that are available for champions that help them to navigate change, and especially in those areas that might be a bit trickier or more challenging. And that can include determining if an adaptation of a guideline recommendation is necessary in order to make it meaningful for your local context. So again, if you access the Blended Learning Series, you'll be able to access the resource library and be able to find all of these job aids. Okay, once we've thought about what does this BPG mean and what does it mean for us, then we want to think about our teams and whether our teams are ready to make change. Again, this is a focus on people. People make change, so they need to be ready to make change. And so as part of the social movement action framework, we talk about the receptivity for change. Are we ready to make a change in our pain best practices? And many variables that influence that, including, is this an area of care that is seen as valued and necessary by staff? If it is, that's something then that acts as a positive driver, a facilitator for change. Then we think about other aspects like timing. What else do we have happening in our organizations right now? Is this a good time to be focused on updating or introducing new best practices in pain? We also need to have available and visible leaders for a change. Again, these are our champions. So again, we have training available through RNAO for that purpose, but having those visible leaders, someone speaking out about the need for best practices in pain assessment and management, is something that can be very helpful as far as readying our organizations for making a practice change. Also, we need to consider, do the recommendations work for us? Do they address an identified problem? In which case, then they're seen to be of use for us. And then are they workable? Are they changes that we can actually achieve? Are they feasible? So are the recommendations, do they work, and are they workable for us? And then do we have the necessary resources? As we know, when we create change, typically we need some dollars, we need champions, we need time, we need education, etc. So when they are present, then that can act as a precursor, or makes us more ready to take action. It supports the emergence of change leaders and advocates, and also supports a positive, high intense energy for change. And we know that energy for change acts as a driver for change. Again, focusing on the people that make change happen. So again, another job aid that comes from our Best Practice Champions Blended Learning Series resource library. And this is a checklist of factors that influence receptivity to change. So again, if you're interested in that, have a look at our Champions Blended Learning Series. Okay, our fourth tip for kickstarting BPG implementation includes assembling a change team. This recognizes that no matter how much motivation, excitement there could be with a new BPG publication and interest in the area of pain assessment and management, we still need a small team to guide and lead a change process. And this is our champions in action. You can see a couple photos here. And again, our change team must have those competencies of being a good champion, like being a good leader, mentor, communicator, facilitator, etc. So assembling a change team is critically important. Again, we have lots of resources to support a change team. We have a section in our social movement action framework on core leadership structures that talks about how to be a change team, who to include, how to work together, etc. And we did a presentation as part of our Best Practice Champions information sharing webinar on strategies for teams who lead change, and you can find the link to that. And then we also have another job aid as part of our Best Practice Champions Blended Learning Series on change teams. So lots of information on this because we know that change teams are essential for guiding and leading a change initiative, including the adoption and integration of the PAIN BPG. And then finally is the completion of a gap opportunity analysis is very often one of the first big jobs that our change teams will undergo. And they'll do this with the input of staff and others. This is when we're doing the comparison, as you know, of what our current practices compared to the good practice statements and the recommendations. And again, we have a number of resources to help you through this process, really an important first step at planning for change and prioritizing which recommendations are going to be areas of change for us. So again, you can see we've got a job aid on conducting a gap analysis. We've got some tips for good gap analysis in our leading change toolkit. These came from our very experienced long-term care coaches, and they share their pearls of wisdom. So you can find that. That's in the middle. And then we also have a gap analysis worksheet. This is a template of a gap analysis that includes all of the good practice statements and recommendation statements. And this is available to anyone in our long-term care toolkit. So anyone, including our BPSOs, can access this, and it acts as then that template to be able to do that comparison of current practices to best practices, and that helps us then to advance as far as the adoption and integration of best practices. And of course, as part of that process then, we also look at evaluation and monitoring to understand the impact of implementation. And for that, I turn things over to my colleague, Dr. Christina Medeiros, who will lead us through this part of the presentation. Thanks.
Thanks so much, Catherine, for such a lovely presentation. So today's objectives with respect to understanding the impact of implementing this really important BPG, we really want to focus on, understanding how these indicators are developed, learning how to select these indicators based on prioritized good practice statements or recommendations, as well as recognize when to start monitoring and evaluating the impact of BPG implementation and gathering those really important team members, as Catherine mentioned, how important it is to have that fulsome team. Learning how to develop a logic model according to a completed gap or opportunity analysis, as well as understanding the importance of sharing data. All right, so we have a pretty fulsome indicator development process at RNAO that really mirrors the guideline development process. So really it is comprised of 6 steps. And so the first step is really looking at that guideline selection where indicators are developed for particular guidelines. And in this case, this is the PAIN BPG guideline. And the next step is really extracting those recommendations and good practice statements. So in this step, the drafted practice recommendations, overall guideline outcomes, and previous editions of the BPGs are reviewed to extract those potential measures for indicator development. We also look at the strength recommendations, as well as the good practice statements, and we look at the outcomes, and we have that feedback that's provided on those outcomes, and we discuss those with the expert panel. Next, we actually start to draft our indicators based upon those good practice statements and those strong recommendations, as well as sometimes conditional recommendations. We also draft our outcome indicators based upon outcomes of the overall BPG, and we align these indicators with external organizations to really ensure that we are adhering to a collect once, report multiple times principle. This means that if you're collecting an indicator for example, for the Enquire database, our nursing quality indicators for reporting and evaluation data system, that this indicator may also be something similar to what you're reporting to the Ministry of Health, for instance. And so we really want to make sure that we are decreasing that reporting burden. We also have in step 4 our practice test and validation. So our indicators go through 2 sets of validation. So when the BPG is actually sent out for expert panel review, we also send out our indicators for review as well. And we send out these indicators in a particular survey looking at quantitative, so numerical feedback on the relevance, feasibility, usability, and readability of the indicators, as well as qualitative feedback. So our expert panel members have the opportunity to provide some additional contextual feedback about why they may have scored an indicator in a certain way, or perhaps some particular edits to the indicator. We integrate that feedback, and then we send it out along with the full BPG and the survey to our external reviewers, which we are so thankful for providing such amazing feedback for indicators, as they really ensure that they are relevant, feasible, readable, and usable to collect and submit data on. And we do the same thing. So we look at the quantitative feedback, we look at the qualitative feedback, and we integrate all of this through our 2 steps of validation. And then we begin to publish these indicators in our BPG evaluation section, which is super exciting. We also develop data dictionaries, and we build these indicators within our nursing quality indicators for reporting and evaluation. And then our final step, which is really important with respect to these types of BPGs, which are next edition BPGs, is the data quality assessment and evaluation step. And so what our monitoring, evaluation, and research team does is that they look at the usage of these indicators. And this allows us to make some important decisions about whether we carry forward indicators, as long as they align with the evidence that is housed in the BPG, or whether we drop certain indicators or replace them. And then our cycle goes around and around. All right, so when should we start thinking about evaluations? So evaluation is usually thought of at the end of a project or initiative, but really it should be thought of at all stages of implementation. It's kind of like as nurses when we think about looking at discharge at admission. So we really want to look at evaluation before, during, and after the implementation of a BPG in a practice setting. And it's really important to monitor the use of the new BPG's recommendations and good practice statements that are introduced. So looking at the knowledge being used and evaluate those outcomes or impact of the resulting change in practice. So we really want to help to answer key questions like, are the BPG recommendations and good practice statements being used? Are staff adhering to these good practice statements and recommendations? Is the implementation intervention working? And what difference does applying evidence-based recommendations and good practice statements make in clinical practice, specific to certain health outcomes? Really important questions to be asking throughout all implementation phases. As Catherine mentioned, we really need that fulsome evaluation team. And we have our BPG implementation lead at the center, as this is the person that is leading this initiative. We also want to make it important to engage people with some sort of clinical experience and leadership who understand how the changes that are made will affect the clinical care processes. We want to engage frontline staff like nurses and other members of the interprofessional team and gather their feedback and help identify how care processes are being affected and what their impact is on persons who are receiving care. Since they're the ones that are implementing these changes, as well as probably collecting this data. We also want to engage senior management or a project sponsor, someone who has that executive authority and can champion the quality improvement project and assist with getting those resources that we need and overcoming barriers that may arise. We also want to share results from our evaluation to help senior management influence those policy and organizational changes and scale up the implementation as well. We also want to engage people with technical expertise who understand the quality improvement process and how health information technology systems work and support these proposed practice changes. So some organizations may have decision support specialists, for instance, or clinical informatics or other IT staff to help with standardizing electronic documentation, identifying data sources, etc. And then we also need to include individuals who exhibit day-to-day leadership, like professional practice leads, to help ensure that completion of tasks such as data collection, analysis, and change implementation are happening. And so really a lot of these people may have different roles or maybe even combined roles. We may have, for instance, decision support who may also be a professional practice lead. But what we really want to leverage is that everybody has a different way of contributing to this BPG implementation. And we really want to make sure that we are leveraging everybody's certain skills with respect to monitoring, evaluation, and implementation. Next, we need to select indicators. And so defining your measurements is really key to ensuring that you get good quality data. So if we were to use this BPG as an example, we've identified in our first step the pain prevention assessment and management BPG to implement. Then we need to conduct a gap or opportunity analysis to identify practice recommendations or good practice statements to implement. So here we may choose, for instance, a good practice statement 1.0. It is good practice for all health providers to conduct initial and ongoing screening and assessment for pain with people in their care. Pain assessment includes a comprehensive evidence-based assessment using a person and family-centered approach. Next, we want to select indicators related to processes, outcomes, and structures. And so when selecting your indicators, it's really important to consider the feasibility of data collection and organizational priorities. You want to ask yourself some questions, thinking about the resources that you have. Who could help you with this project? Who can help you obtain this type of data? And think about where you can get this data. Where are you housing this type of data on pain, for instance, on pain assessments? Is it on a paper chart? Is it on an electronic chart? Or a combination of both? And is pain prevention assessment and management part of quality improvement plan that needs to be submitted perhaps for certain deliverables for funding? So wherever possible, it's really important to choose measures with data that you're already collecting. And that'll make your quality improvement project a lot more simpler without compromising on quality. So for instance, you may be collecting data on worsened pain rates that you may be submitting to certain organizations. And the requirements to meet these, to measure this indicator is the same, so you can consider collecting on this indicator as well. And you may find this very useful to collect on to demonstrate the impact of implementing this BPG. And next, you need to consider the level of implementation, as well as select indicators that align with the BPG recommendations. So we've selected the indicator with respect to assessment for a good practice statement 1.0, and also consider, is this guideline recommendation or good practice statement implemented on specific units or specific areas of the organization, and then rolled out throughout the whole organization. So certain steps you need to consider when you're selecting indicators. As Catherine mentioned, we also have a really important mapping document. So if we're to look at, for instance, our good practice statement 1.0, and we were implementing a previous edition of the assessment and management of pain, third edition, we could see that the percentage of persons who received a documented comprehensive assessment for pain in the 2025 version is aligned with the measures in the 2013 version. which is a percentage of persons who were assessed and treated for pain, as well as those who were screened positive for pain with documented comprehensive assessment using a standardized tool with established validity. So here again, we can kind of leverage what we're already collecting to demonstrate the impact and track the BBG implementation. So we've conducted our gap or opportunity analysis, and we found that we want to implement the good practice statement 1.0, which it is good practice for all health providers to conduct initial and ongoing screening and assessment for pain with people in their care. Pain assessments include a comprehensive evidence-based assessment using a person and family-centered care approach. So we're going to focus on pain assessments. And we're going to create a logic model or an evaluation plan. And this really shows and sets out the details of evaluation that reflects what will be evaluated, how and when. And this is kind of like a roadmap in really looking at the route traveled or the steps taken to reach a certain destination. And it identifies both the processes used and outcomes to be achieved. And it also identifies how success will be measured. So evaluation plans are not necessarily created in one sitting. People involved in creating the project usually brainstorm and map out a preliminary evaluation plan. And others involved, such as staff, etc., should be consulted to refine the plan. So here is a logic model. So for example, we are looking at our good practice statement 1.0 to be implemented. And here you can see in blue that there are certain inputs. And these are resources that are needed for this project. These may include a clinical educator, for instance, funding, professional practice lead, educational materials, and a valid assessment tool. Next are the activities in orange. And these really what you want to ask yourself is, what are the activities that will need to be carried out as part of this project? We may need to conduct education workshops about conducting pain assessments, perhaps create educational pocket cards for health professionals, maybe even update documentation to include the assessment tool. Then we move on to our outputs, which are the products that are produced from the activities in orange. And these usually provide a numeric value or attributing percentage. For example, the number of nurses trained, the number of workshops conducted, etc. And then you have your outcomes, which are both short-term and long-term. And these are really associated with changes in knowledge, awareness, behavior, and skills. So here we can see that there's increased awareness and knowledge, as well as the increased use of the assessment tool. And this can be measured by our process indicator, percentage of persons who received a documented comprehensive assessment for pain. And then we have our longer term outcome, which is associated with improved effective pain relief. And that corresponding outcome indicator is the percentage of persons who had documentation that they experienced effective pain relief. So we know that knowledge is a critical element in understanding whether clinicians understand, accept, adhere, and apply evidence-based practice recommendations and good practice statements. Monitoring knowledge use really helps us understand the question and answer the question, are recommendations and good practice statements being used? Is the implementation intervention working? During your implementation phase, you're really trying to monitor knowledge use to really provide insight on the rollout of the implementation activities as well as practice changes. And so you can really look at two types of knowledge use to measure. There's conceptual knowledge use, which is looking at understanding. So that's a knowledge that describes a health provider's understanding and internalization of knowledge and information. You can measure this by administering perhaps a knowledge test before and after an educational session on conducting these assessments to really determine whether participants understand or learn the evidence that's supporting that good practice statement 1.0 that really supports the conduction of those pain assessments. And then we also have instrumental knowledge use, and that's the knowledge that's being applied in practice, and as a result has an influence on behaviors or actions. And this is the application of knowledge. You can measure this by doing, perhaps a chart audit to determine if assessments are actually being conducted. So now we have all this data, and we really want to share this quality improvement data. But why is this important? Well, within healthcare, we use a range of data at different levels of the system. Perhaps at the person level, we may collect things like blood sugar, pain intensities, temperature, blood test results, etc. At the service level, we may collect certain data on waiting times, outcomes, or collated feedback of patient experiences. At the organization level, we may collect data on staff experience or financial performance. And at the population level, we may collect data such as mortality, quality of life, etc. But for the purposes of today, we're going to be talking about sharing your quality improvement data, which are generally anonymized or de-identified or aggregated at various levels like units, programs, or at the organizational level. And so there's really a number of reasons why it's really important to share your data. First, it really helps others understand the impact of evidence-based practices on outcomes. It's also an important way to engage your frontline staff, those who are really making that change. We've heard from organizations time and time again that it can be really rewarding for staff to see those positive differences that they're making on the quality of care. At the same time, it can be very motivating when you show data that indicates a gap or a need in care that requires improvement, and you make those improvements and you see that data change for the better. It can also allow for rapid learning and feedback and wide-scale spread of best practices and improvements. And most importantly, having access to this data in daily practice is really critical in understanding the gaps in care, which allows us to learn and improve the way we care for our patients or the persons we provide care to. And in some way, also care for our staff. So if you're sharing data for quality improvement in your organization, it's so important to do so to not only motivate your staff, but also improve the quality of care that you're providing to persons. So a couple of next steps, given that this is a bit of a flyby of monitoring and evaluation. But what you really need to think about is identifying your implementation and evaluation team, conducting that gap analysis, selecting those indicators and developing that logic model, as well as a plan for standardized data collection and beginning that baseline data collection, because we know it's really important to show the change that you're making. I think I'll hand it over to Glynis.
Perfect. Thanks, Christina. If we can just go to the next slide. Perfect. So before we begin the Q&A session, we would like to inform you all that the BPG is now freely available for download on the RNA website listed on your screen. I will also include it in the chat box. Just to let you know also that today's webinar will be available on the RNAO website at the same location. And if you have any other questions, please feel free to contact us via our website, or you can also contact myself, Glynis Gittens, Project Coordinator, at ggittens@rnao.ca, and you can also see my email listed on the screen. So just before we end the webinar for today, we just want to thank you all again for attending, and we do hope that it was informative. I will now stop the recording and we will begin the Q&A session for those who have any questions.